Yes, first of all, thank you so much for the organizers for the opportunity for us to share our data. At Ambry Genetics, we are very enthusiastic about sharing data because we strongly believe that that's the best way to help to move the field of personalized medicine forward, right? So I think that this is the most important actually information we provide today. Like we have currently over 1 million tumor suppressor alleles sequenced. So, and why? Because we were one of the pioneers to introduce next generation sequencing for testing of hereditary condition, right? And this is reflected on the numbers of patients that we have tested. So we have performed, and this is last year numbers, so we have performed over 40,000 NGS multi-gene cancer panels so far, and roughly over 1 million tumor suppressor alleles sequenced. And this is a fantastic tool. So as a variant assessment point of view, when we try to classify variants, we use in silico data, we use functional data, but allele numbers and clinical information still is the most important way and the most helpful tool for us to classify variants as pathogenic or as benign or unknown significance. So here I will share briefly a few examples because these numbers allowed us to make several observations that have impact on clinical management of these patients with hereditary conditions. So I'll share a few examples of this, including our experience with colorectal cancer panel. And also, we were the first to introduce the next generation sequencing test for BRCA1. So also a little bit of our experience with this. So first of all, because of time, I will just briefly discuss our data. But if you are interested, all this is published, so you can have access to the literature. So this is just to give an overview I think it's very interesting that in the past we used to sequence things based on phenotype, right? You have a phenotype, so we're going to sequence CDH1, we will sequence TP53. Now the multi-gene panels allowed us to sequence a lot of things at the same time. And as a result, we can see that there is the ratio, the distribution of the mutations, it's very broad. Right, and this is, I think this is reflected on our colorectal cancer panels. As James Ford was saying before, there is a paradigm shift right now. Before, when I started working with oncogenetics over 10 years ago, you have hereditary, you have diffuse gastric cancer, family history of gastric cancer. You go and you do a Cadherin Sanger sequencing, and then you find a variant and you conclude that that variant is pathogenic. Now we do things the other way around. We go there, we sequence a multitude of genes, and then we find many times mutations that do not match the phenotype. And I think that's particularly interesting in the colorectal cancer case. So here you have an example, a small example of our results from tests performed, our colon-X panel for hereditary colon cancer from March 2012 to 2013. So you can see there that we around 10%, around 12% of the cases we have a positive diagnosis. In around 8% of these cases, it's actionable. So that's very significant. But most interesting of all, as I was saying, overall, 29% of the cases, they did not meet diagnostic criteria. So these were people that would not have been diagnosed just based on the well-established diagnostic criteria, right? So for like age NPCC, for example, around 20% do not meet criteria. For FAP, 40% do not meet criteria. For GPG, even more, like 50% do not meet criteria. So if you follow the old rules of like you have the criteria, you sequence the gene, you would miss a lot of these patients. In another great example, the breast cancer, right? Hereditary breast cancer panels. And I think this is actually very interesting and very opportune because, as you may know, yesterday was the final decision from the Supreme Court. So the BRCA1 patent story is over. So the decision was made, and there is no way back now. So you know that some time ago, yes, like last year, the decision was initially made, but there was still some room for appeal. But yesterday, no, all the charges were dropped, and now we can say that yes, your genes are free forever. Nobody will patent any of your genes, and I think that's specifically for the genomic industry. That's very important, because had the decision been different, this would have a huge impact on how genomics would be applied for clinical practice, right? So we were the first one to introduce next-generation sequence BRCA1 tests, and that's very relevant clinically because more than half of the individuals meeting NSCN criteria for hereditary breast cancer, they do not have BRCA1, BRCA2 mutations. So if you limited sequence only that, you would miss a big part of those patients, right? And this technology allows us to perform simultaneous testing of other genes that we know that are relevant for this disease, and that there are medical management guidelines for mutation carriers. So this is definitely clinically relevant. And the utilization of next-generation sequencing and CGH, it's more and more becoming more cost-effective and more part of the everyday clinical practice, right? So since we were the first ones to implement this, we of course had to go through the steps to validate our tests. So this is published in PLOS One, so you can see if you want to check by yourself. So we did test around 250 samples with around 3,000 previously defined germline variants, right? So going from synonymous to splice site to nonsense mutations. Our test was able to identify variants in 100% of time. So we had 100% sensitivity. And in terms of analytical specificity, our false positive rate, we got 30 false positive cases out of 5.79 million base pairs analyzed. So this gives us an analytical specificity of 99.99%. Right? And of course, as good practice, every variant that we identified with NGS, we will send your sequence, right? So every variant that is reported to our patients, it will be send your sequenced. So this is just like the distribution of mutations for our first 3,000 BRCA plus tests, and you can see the majority of cases is associated with BRCA1 or BRCA2, but there are another important players, and I will focus here on TP53. As you can see, around 10% of our positive tests for hereditary breast cancer were P53 positive. And we did learn some interesting things, and I'm just going to use this as a small example of how genomics it's already have a big impact on clinical management. So as you can see here, in terms of P53, around 50% of the cases, they meet criteria for P53 testing, but the other half, they didn't. And this for multi-gene panels, right? But this is, if you compare with the single gene test, of course the number is different, because you usually will ask for a single gene test if the patient already meet criteria, right? That's why you go and sequence this. But if you look at NGS, we were able to identify TP53 mutations in around half of our patients that do not meet criteria for TP53 testing to start with. And for example, this is the NSCN criteria that I was talking about, and more specifically that one, the early age of onset for breast cancer, right? So an individual with breast cancer with less than 35 years old, diagnosed with under 35, it is recommended right now to do TP53 mutations in case of the BRCA1, BRCA2 testing being negative. But our data indicates that there is a large number of patients that their phenotype is breast cancer. And if we do use the 35 as the age to screen, we would miss a significant part of this number of these patients, as you can see there. So we see patients over 50 years old that have classic TP53 mutations that their only phenotype is breast cancer. And here is just another pinpoint example, like for our index patient there with tumor diagnosed around the 50 50 years of age. So our conclusions, genomics is here to stay. It's not going to go anywhere else because it's very well established already, the benefits. And I think we're still learning. There is so much more we can learn. And no question that the contribution for oncology, it's just the tip of the iceberg. NGS panels have an important role in hereditary cancer diagnosis, particularly in a typical and overlapping phenotype. So remember the colon cancer, sometimes you do not have criteria, but when you do sequencing, you are able to identify mutations and then you can enroll patients for the correct management. But at the same time, this also generates some questions too. If, for example, hereditary diffuse gastric cancer, if you have a mutation, but you do not have medical history of diffuse gastric cancer, are you going to recommend prophylactic gastrectomy? So there are so many things that we still don't know, we're still learning. So I think it's a very exciting time to work with genomics because we still have so much to learn. And I think in the end, the patients will be the ones that benefit the most. And finally, as a variant assessment specialist, of course, interpretation is the most important step. Everybody can do sequencing nowadays. It's easy, it's affordable, but you need strong numbers. You need a strong team to be able to provide the correct classification. And we believe we need trained oncogeneticists, people that understand genomics, genetic counselors, bioinformaticians, and the list goes on because this is very important. Thank you very much.